My name is Jim O'Keefe, and this is one of our webinars looking for lessons from the front line. I've tried to reach out to people who are actively involved in taking care of patients with COVID-19 and ask them to share their experiences with us. I've listed our speakers here on this first slide. I would like to give them each a detailed introduction. Unfortunately, I can't because we're tight on time. It was just too many people involved in the care of our discharge patients to do it justice. So next slide. So as with the other webinars, our content is for educational purposes. We're trying to share experiences and promote dialogue. And the content will be visible on the Emory Department of Medicine YouTube, and we have a specific playlist there. I hope to do future clinical content to continue to work with all the great collaborators and colleagues here. And there will be a survey at the end of this webinar if we are able to fit it time-wise to ask you for input about that. So thanks, everyone. With that, I'll turn it over to our first speaker.
Hi, thank you so much for having me. I'm Ariel Summer, and shout out also to Dr. Sun Yu, who is managing our program here at UCLA for our post-discharge patients. Next slide, please. So just very briefly, this is for patients who have been confirmed by PCR COVID positive, hospitalized in our system, and discharged to home, and able and willing to participate in telemedicine visits either by telephone or video. And we are having our inpatient case managers and nurses help them set this up before discharge. Next slide. So this is our workflow. So on the day of discharge, the patient is given a pulse oximeter and also teaching on how to use this. On the first 2 post-discharge days, our hospitalist or our nurse practitioner in the hospital medicine side calls the patient and does either video or telephone visit. On day 2, our case managers in the outpatient program enroll the patient in our program. And then on day 3, they have their first appointment with our outpatient COVID doctor. And then from day 3 to 7, either the nurse or the doctor has appointments with the patients, and day 7, or when the patient is ready, we discharge them back to their primary doctor. Next slide, please. So our nurses, as you can imagine, with many things, are the most important part of our program, and this is their workflow. So the first appointment with the MD, they note how often the MD is going to do the appointments with the patient based on how many symptoms they have or the degree of complication. And then the nurse will have appointments with the patients on days where the doctor does not. They add all the patients then to a HIPAA-compliant shared Excel spreadsheet, perform their symptom questionnaire on the days indicated, and then can do it as needed when the doctors are asking them for more visits, and they're paging with any alarm symptoms. So in terms of what these questionnaires are, we can go to the next slide. I have it listed here. This is a work in progress. This was developed by our team of doctors. And basically what you can see here is that really it's about new or worsening symptoms. And it really hones in on those things that we're most concerned about in terms of severity of illness in our post-discharge patients. And we really put a lot of weight on the oxygen monitor and saturation. These are just a few of our alarm symptoms, and this is a changing document as well. Next slide. Dr. Benjamin Waterman at UCLA has developed with our IT team an incredible patient-facing symptom tracker that's actually the exact same questions that our nurses are asking, but the patient fills it out on their MyChart app. It gets linked to the primary COVID MD's in basket, and then they review it each day. At the end of the survey, it also tells the patient, call 911 if they have any alarm symptoms, page your doctor, which they know how to do, or continue to fill out the survey. And then our nurses are monitoring these very carefully as well to look for any flag symptoms. And there are ones that come in at higher levels than others, depending on what the patient clicked. And there's also room for population management, which we're hoping to kind of get into more as we have more patients. Next slide, please. So what has been our clinical experience? So we've really been seeing a huge spectrum of how patients are doing post-hospitalization. Some patients are doing incredibly well and really only need one visit with the doctor. And then other patients are having daily visits with the doctor and daily calls by the nurse and lots of case management issues and lots of continued symptoms. So as many of you know who are caring for these patients, there's a really prolonged recovery from this illness, and it sort of has a waxing and waning component. So it's been difficult to tell, is this a new process that's developing if they have fever and chest pain and cough, or is this just the COVID kind of not quite improving yet? And what we found is that while labs and imaging, are sometimes helpful, the majority of the times we can actually manage this just by vital signs at home. So having that pulse oximeter has been incredibly valuable. Also, a lot of physicians are doing walking sats. We're doing orthostatic vital signs if they have a blood pressure cuff. And if not, we're just doing orthostatic pulse. Some of our doctors are seeing a POTS-like syndrome happening as well. So this has been helpful in differentiating that. Our patients are hugely deconditioned. So, as you imagine, they are not getting physical therapy. They're not having as much nurse touching in the hospital. They don't have family members with them. They're basically laying in bed and also severely ill. So they're coming home more deconditioned than they would have in prior hospitalizations. And then the anxiety and the PTSD for our patients has been quite remarkable. As you imagine, many people are frightened of this illness, but also when they get resurgent symptoms, I think they panic a little bit. They're also scared about spreading this to their family members or to vulnerable populations, and they feel just really far from their baseline. Even when they're discharged and they're kind of better, quote unquote, they are not like when they came into the hospital, which is scary for a lot of patients, especially young ones. And then as far as late complications, we're learning more and more about this. I think the things that I personally worry about are late neurologic complications and residual pulmonary complications as well. I'm going to the next slide. So some logistical things that have come up have been interesting. So one is when to discontinue quarantine. So our policy at UCLA is to discharge patients, asking them to do 14 additional days of self-quarantine at home. We make sure they have 14 days of medicine supply with them, that the case managers call and have groceries delivered and all their home supplies as well. But discontinuing, as you can imagine, is really an individualized discussion. It's very different for the patient who has been feeling very well, no fever for 14 plus days, and really far out from where their symptoms started, versus the patient who's continuing to have fevers and cough and chest pain. Caregiver education is crucial. So this has been something we didn't anticipate, is how little the caregivers have been involved in the patient's care, not being able to be at bedside. And they're terrified, when your loved one calls you saying that they're having a fever or they're short of breath or they're having a cough, the caregivers panic. They can't see the patient, they can't help them, and so they want them to call 911. Additionally, for in-person visits, we have decided as a UCLA health system that we would do 14 days past discharge. And that is just something we've decided based on how sick our population is here. And then, of course, using translators, we've had some issues with, so we've got that sort of figured out on the telemedicine side. And then transportation, dialysis, and home health. So there are transportation companies that are transporting COVID patients, but as you imagine, the staffing can be variable. So sometimes they don't show up. And then the patient misses their dialysis. And so our case managers have really been helpful. They've been on board since day 0 at discharge with the patient, even before they're officially enrolled into our program. We do have one dialysis center as well that is having all of our COVID patients and then return to their home dialysis center. Is kind of similar to what we're seeing with home health agencies, in that each center has somewhat of a different protocol. So some centers require repeat testing to be negative, some it's based on symptoms, some it's based on time. Home health agencies, have issues with staffing, and they also have issues with PPE. And so we're not always able to get the physical therapy or the nursing as frequently as we had previously. And then, of course, we have to sort of comply with all of the different protocols with each home health. So again, case management has been crucial. We had about 80 pulse oximeters when we discharged, when we started this program. And obviously, if we exceed 80 patients, we're going to run out of them. So either we're going to have to buy them again or find a sanitary way to recycle them. And then we had a lot of discussions about weekend management and decided that our nursing staff will do the calls with an MD escalation for alarm symptoms. Go to the next slide. So our approach is really threefold. It's this clinical aspect, care coordination, behavioral. So having, it turns out, this reliable, regular contact with patients not only eases their anxiety, gives them a resource so they don't feel like they just have nobody after being hospitalized for this severe illness, but it also allows us to identify early symptoms, to treat them, to triage them, and to potentially prevent ER readmissions. Caregiver engagement, like I said before, is crucial, and a lot of our MDs are doing this on the first visit, making sure that we have the caregiver either on the phone or joining remotely via video visit so that we can really enlist them in our care and utilize them. Case management, as we discussed, is incredibly crucial to our program and does reach out to the patients and is available for our inpatient transition as well. And then Dr. Yu is doing IDRs almost daily with our infectious disease specialists. And many of us are really being home physical therapists, and we're being mental health professionals, and we're walking our patients through makeshift physical therapy regimens and talking to them about dealing with stress and anxiety and having to get really creative with what types of medicines we're giving for, panic attacks, not wanting to suppress their respiratory system with things like benzodiazepines. Go to the next slide. So we're growing in our number of resources. Currently, we have a 24/7 RN hotline, so patients can call in, and it's similar to everything else, where if there's any alarm symptoms, they page the weekday or weekend MD. And then our mental health associates have also reassured us that they will have very quick access to telemedicine appointments for our patients. And I included a really helpful link that you can send out to patients as well. And then myself, along with some of my other colleagues, are interested in starting to develop group visits via Zoom for these patients, both as a how to manage stress and anxiety, how to manage symptoms, but also a little bit of group therapy so that they can talk with one another and really share their experiences. And then, of course, we have telemedicine consults available same day or next day with our specialists. Next slide. So these are our preliminary outcomes. We're hopeful based on this data, it's very early, but we're hopeful that possibly with this program, we're able to prevent the preventable readmissions, right? Those things where if they just had a doctor to walk them through it, or we could catch something early and start antibiotics right away, that we would prevent them from going back to the ER. And preliminarily, this is what we're finding. Next slide. So finally, we're continuing to learn about these patients. So on the day of discharge to their primary care doctor, we ask either the primary care or us to follow up in about 14 days to do another check-in. And then to day 30, 60, and 90, our nurses are calling and documenting this on our shared spreadsheet. And so we hope to continue to learn from these patients. So thank you very much. That was a quick overview of our outpatient discharge program, and I look forward to working with you more.
Thank you, Ariel, for sharing that. I thought it was neat because we're dealing with a lot of the same issues at different centers across the country. So it was just really generous of you all to share your knowledge with us, and hopefully there will be future opportunities for collaboration. Our next speakers are from Emory's program, and there will be several sequential speakers.
Thanks, Dr. O'Keefe. Next slide. So as things have evolved in the Emory Healthcare as well as in the Atlanta market, very early on, Emory Healthcare began to plan for a possible onslaught of inpatient admissions into our facilities around the pandemic. We began to quickly mobilize our resources to the inpatient facilities, even sharing and sending our registered nurses over into the inpatient settings, really preparing for what we appeared to happen in New York would currently also happen in Atlanta. That didn't quite happen, but as time evolved, as we were admitting patients in the inpatient facilities and discharging them, we very quickly recognized the need to provide additional support to the patient populations being discharged from our inpatient facilities to home. Similar to UCLA, we set up a very similar program around transition care management. And one of the things I would like to highlight is that we forged a very strong partnership, a very strong physician partnership with hospital medicine services and primary care. This gave us the ability to have intentional communication and collaboration amongst this population and to support the patient transition of care from the inpatient to home setting. With that being said, we have developed many new workflows and developed tons of relationships across the system that will be able to allow us to continue this work in a multitude of other patient populations that can benefit from these types of services. The support that we provided to the patient population was very much so individualized and patient-centered. And so Monica, an RN care coordinator on the ambulatory care coordinator team, will tell you a little bit about some of the individualization that needed to happen to support the patient population's discharging. With that being said, our solid ambulatory care coordination model as well as the high touch follow-up required in the patient populations really have served to be quite beneficial in transitioning these patients and reducing readmissions. We have received numerous emails thanking the team members for their work. Why have we not had a program like this similarly before? What can we do to continue to make sure that we have support from registered nursing on the outpatient side to transition patients into the community? And all of this is really based on some 4 key fundamentals: education, advocacy, support, and of course, the goal of readmission reduction. And I think as a healthcare organization, if we continue to keep that in mind and individualize our patient-centered care that we are providing, we can be very successful in a number of other populations as we move forward. Next slide. So as I begin to really think about the work that had occurred over our pandemic time and all of the partnerships that we forged in a very short period of time to support a very vulnerable patient population, a model was developed. And it basically depicts exactly what I've already spoken about: a very strong, connected partnership with primary care and hospital medicine physicians. And when I say primary care, I mean internal medicine specialties, family medicine, and what have you. The triangle in the center, of course, depicts the COVID-19 discharge patient, and the time that the patient actually spends with the physicians is very little. They're really much on their own after discharge and really left to understand what's their next steps for them on a daily basis. The strong pillars of communication and collaboration tying into the ambulatory care coordination team, that's a multidisciplinary team made of nurses, social workers, and advanced practice providers. Of course, leaders really supporting the feedback loop that we've created back into hospital medicine to reduce their anxiety and fears around discharging their patients, as well as reducing the fears and anxieties of the patients and their families. And so based on those 4 pillars of education, true advocacy, and support, we have been really successful in readmission prevention, as well as partnering with the team. So I will turn it over to Monica to share with you her perspective as an RN care coordinator in working with the patient population. Monica?
Thank you, Misty. One of the major components of the home discharge transition is the post-discharge assessment. A key requirement of the assessment is cultural consideration and awareness. The assessment must consider all populations, especially those that are not predominantly found in your community. A crucial component of the assessment is utilizing the language line to connect with various cultures. However, you must be mindful. Because of the multiple dialects in each population, the language line may experience communication challenges, and that's some of the things we've been seeing with our assessment. There is an increased fear amongst most marginalized populations, and often during the assessment, they disclose all the information needed to complete the assessment. Factors noted from the assessments were perceived public and media perception, the stigma of being COVID-19, misleading information amongst the communities about COVID-19, concerns for various generations of family members living in small accommodation. Fear factors included discharged patients becoming reinfected with COVID-19 and spreading the virus to elderly family members in the household. I found that social distancing is nearly impossible due to generational family members residing in close quarters. Some of the examples that you can provide to explain social distancing are a sofa that seats 3 people is about 6 feet. Another example I utilized was the length of a room door is about 6 feet. I also designate a small sub-area in the home for self-isolation. Increased education and awareness is so important. Emphasize and stress wearing masks and hand washing for 20 seconds. The key component is empowerment. By having family members participate in the assessment, they can reinforce social distancing in their language and dialect to other household members and the community at large. There may be transportation obstacles and challenges due to social distancing. Key points that I shared with my patient was stay away from the public transportation. The use of a large van or a vehicle as possible. Encourage family members to have one family member designated to transport each patient. Stress the use of masks at all times. And then try riding with the window down as well. We also know what our self-assessment was: self-management discrepancies. It's a result of variation in understanding of the discharge instructions. We cannot make any assumptions based on a patient's education level. Utilize the language design. Ask open-ended questions throughout the home instruction, and utilize the teach-back method. Some examples of the open-ended questions that I ask we ask, tell me your understanding of your home discharge instruction. When will you seek medical help or call your doctor? What's your understanding of COVID-19? What concerns you the most about the COVID-19 diagnosis? How do you and your family practice COVID precautions? Describe your understanding of asymptomatic symptoms. And that was the most challenging, describing what asymptomatic means to that particular family. The goal is to measure the patient's understanding of the discharge instructions, confirm post-discharge follow-up, appointments, confirm retesting, encourage household testing, and provide testing location and resources, and provide any other additional resource information in the proper dialect. In the final analysis, cultural awareness, family engagement, open-ended questions, utilizing the teach-back method, and most of all, trust leads to compliance and prevention of hospital readmissions. Thank you, Dr. Tangu.
Hi, I'm Prathima. I'm one of the hospitalists at Emory Midtown, in Midtown Atlanta, and I'm going to be speaking about the discharge of COVID-19 patients. Next slide. I'm going to be briefly talking about discharge challenges as well as our VTE prophylaxis and treatment guidelines. Next slide, please. So when to discharge, that's a complicated question. As Ariel had mentioned, there are variable presentations of COVID-19 as well as variable recovery from COVID-19. We do have the typical triad of fever, cough, and dyspnea, as well as patients that have malaise, and diarrhea, as well. We do have patients that maybe recover from their initial symptoms of dyspnea and cough, and then suddenly start to have fevers, and so their hospital time becomes more extended. We do look at fever curves to make sure that the fevers are improving, though they may have low-grade fevers on discharge, and we recommend that they check their temp. We also look at symptomatic improvement of the initial symptoms, as mentioned, as well as O2 requirements, making sure that they are not needing oxygen on ambulation if they're on room air, and that oxygen requirement, if they're not on room air, is feasible at home. In addition, this has been talked about already, but there's an emotional component with having COVID-19. Many of these patients this is the first time they're in the hospital, or one of the only times they've been in the hospital, and now we're suddenly wearing PPE. We're talking about code status, so it's a very difficult time for patients. In addition, many patients are watching the news in their rooms, so I encourage them not to be watching the news because it can lead to further anxiety. We encourage Zoom family meetings, which we're starting to do on the floor, or have patients get in touch with their family members on another video app, just so because they no longer can have visitors in the room, so they can have a connection, a social connection. We also have to provide a lot of reassurance to patients, which sometimes means phone calls to their rooms at the end of the day, and if permitted, we talk to their family as well, because family, there's a significant amount of anxiety with family members. So next slide, please. We actually have more than 650 EHC discharges. This is a statistic from a couple of days ago. Actually, last night it looked like there were actually 900 discharges from all of the Emory healthcare systems, which is amazing. We are very grateful towards the PCP, their office staff, the APPs, and the care transition coordinators, because as mentioned, it is a journey to recovery at home. Patients are not feeling 100% when they're leaving the hospital. I'll briefly touch on some discharge barriers. Some of these are not huge issues anymore. So the homeless patients and some patients who couldn't self-isolate. The social workers were working with Department of Health in getting alternative housing. In addition, initially our ESRD patients, they were improving, but we didn't have dialysis slots. Many of the centers in Atlanta are taking patients back and cohorting patients on certain days who have COVID-19. In addition, they may be working with a sister clinic. This isn't at 100%, but it's very close to 100% from what I've talked to, from what I've learned from our renal social workers. The rehab and nursing home population, nursing homes taking back some of their patients or rehab that's needed, that is an ongoing challenge and probably the biggest challenge for us right now. Some nursing homes were asking for additional swabs, which initially we didn't have enough swabs. Now that's not an issue, but as everybody knows, patients may have been symptomatically improved, but still shedding virus for several weeks. So that has been an issue, but it's becoming slightly less of an issue with the National Guard cleaning some of these nursing homes and being able to isolate more patients. Next slide, please. So VT and prophylaxis guidelines was developed. Initially, it was worked on with the ICU, but Department of Medicine got involved for floor patients as well. For more info, this Emory website for healthcare professionals for COVID-19, I would refer everyone to that because there's more detail in a Word document, as well as a more detailed slide. I adapted this slide from the website. So the thing to know is level 3 is known or suspected VTE, as well as patients who maybe have been in the ICU with multi-system organ failure or increase in dead space, sudden increase in oxygen requirements. These patients are discharged with the standard 3 months of DOAC, which is preferred, or can be low molecular weight heparin. Level 1 and level 2, the difference is the D-dimer of 3,000 is what we're using as cutoff. So it should be greater than or equal to 3,000 is level 2. And it's encouraged to get Dopplers on these patients if available, and we would discharge them with 4 to 6 weeks of a DOAC. Level 1, there's a little bit of a typo, it should be less than 3,000, and we would be discharging patients with 7 days of a DOAC. Next slide. So this has our dosages. Again, I refer you back to that website, but our level 3 is our standard dosage for VTE because again, this is a 3-month standard dosage for patients who have known or suspected VTE. They're in level 3. Level 2 patients are those that have an elevated D-dimer, no VTE. They get 4 to 6 weeks of Xarelto or Eliquis. This dosage is the standard, maintenance dosage that you would have used for a VTE. There's none of the loading of 3 weeks with the Xarelto or a week with the Eliquis. And then level 1 is just 1 week on discharge, and that's 2.5 milligrams BID of Eliquis or 10 milligrams of Xarelto. We have an outpatient pharmacy on site that is working with patients if this is not financially feasible. In addition, for the 1 month patients, which would be the level 2, there are some 30-day Eliquis coupons available. And for level 3, I believe you could, if the patient had insurance, use this $10 monthly copay, which can offset some of that financial burden. Next slide. So that was a quick overview. Again, I refer everyone to the Emory website that's accessible to everyone for those VTE guidelines. Thank you very much.
Hello, everybody. Nice to be with you. My name is William Bryson. I would like to address my section today of this webcast to those of you with limited experience in the post-hospital care of COVID-19 patients. So the way we're going to go about this is looking at similarities and differences in post-discharge planning for COVID-19 versus non-COVID illness. I'm going to use a case study to illustrate the points, and we're going to springboard from there to limitations and benefits of telemedicine for post-discharge care. Next slide, please. So first off, how is a COVID-19 discharge similar and different? Well, it's similar if you think about it from the perspective of COVID-19 really is in some ways a community-acquired pneumonia. So when you are doing post-discharge work with COVID patients, you're going to do the usual data review. You're going to look back through the emergency department presentation, admission, the hospital course, the consults, the lab testing, the discharge summary. You're going to treat it like a community-acquired pneumonia discharge. We've all done them. It should be reassuringly familiar. When you contact the patient, you are going to check in with them. You're going to make an assessment of their current status and their trajectory. You're going to make sure that they understand the treatment plan, that they're following it. you're looking for alarm signs and symptoms, checking all the things that we should normally be checking. Do they understand the plan? Do they have their medications? Do they have adequate supplies? Do they have their follow-up visits scheduled? All, again, reassuringly familiar. Now, differences, VTE prophylaxis is a big difference. So you want to make sure that patients have a clear understanding of your institution's protocols for VTE prophylaxis. Is your patient on a DOAC, which is preferred because of beneficial anti-inflammatory effects, or are they on low molecular weight heparin? Whichever medication they're taking, do they have an adequate supply? The hospital pharmacies and the coupons have just been a godsend on this. I think back to a patient I saw a few weeks ago with telemedicine, and there was a bit of a gap before we got our processes up and running on the anticoagulation. All that's been ironed out now. As I said, the coupons have been great. Prior authorizations are a little bit difficult for Lovenox. Differences, isolation. So you want to make sure your patient has a clear understanding for the duration of their isolation and why. It's important to explore possible barriers to isolation. Do they have adequate social support? Can they get their groceries? Can they get their medications? Are their finances okay, or have they been off work for several weeks and the rent's due? So it's important to talk through all that with your patients and their families. For the end of isolation, we're using the CDC guidelines. So you can end isolation when they've been afebrile for 72 or more hours and their symptoms have improved, and it's been 10 or more days since the onset of symptoms. Comorbid disease, we're all accustomed to community-acquired pneumonias and acute metabolic insults having damaging effect on comorbid disease, but the effects with COVID-19 are particularly damaging. You know, I think about a patient that had epilepsy who had been seizure-free for over a year. His presenting complaint was status epilepticus. I think about a relatively healthy older patient with simple hypothyroidism and hypertension who ended up with AFib and renal disease. We'll talk about that in a few minutes. You want to pay specific attention to the COVID-specific review of systems. They're the atypical signs and symptoms with COVID, but particularly important is to track what could appear to be seemingly mild dyspnea and a cough. You know, the silent hypoxia that we've heard discussed is a real concern, as is investigating any possible signs or symptoms involving PE or DVT. Next slide, please. So next is a case. So presentation, this was an elderly female in her 70s. She had a history of mild hypertension and hypothyroidism. She's pretty well controlled in terms of both of these illnesses, you know, a 70-some-year-old on only 2 medications. She presented with 5 days of diarrhea, loss of taste, a mild cough, relatively mild illness, but her family was concerned about dehydration because the diarrhea had been going on for several days. She was admitted. She was found to be febrile. Chest x-ray demonstrated a possible pneumonia, but it was unclear even at the time of admission. She was later found to be COVID positive. Supportive care was begun, but her hospital course was complicated by respiratory failure. She ended up intubated for 7 days. She developed acute tubular necrosis requiring renal replacement therapy, which is continuing to this day, outpatient. She even suffered cardiac complications with a new onset of atrial fibrillation with rapid ventricular response. She had to get several loads of amiodarone and cardioversion. She even had a GI bleed. So the effects on comorbid disease and perhaps new onset disease of COVID are pretty pronounced. She was hospitalized for nearly a month, but is home, isolating. She remains on oxygen. She's getting dialysis. She's on amiodarone now for her AFib. She's on apixaban as well. So this is a patient with new diagnoses at discharge of hemodialysis. She is requiring renal replacement therapy. Her GFRs pre-admission were in the 60s, and she dropped to a nadir of about 14. She's now steadily improving, but she went in relatively healthy. Now she's on hemodialysis. She has AFib. She's had a GI bleed. So there's lots to arrange and you know, lots to make sure that we're following up on properly. She needs an EGD. She needs to get outpatient. There's concern with infection related to COVID patients. There's no cardio and GI follow-ups. But one thing that's important to remember is that in spite of all of this sweet lady and her family are absolutely thrilled. She's at home, she's doing better each day, and she's really grateful for the care that she received at Emory. Next slide, please. Limitations and benefits of telemedicine in COVID-19. So limitations are obvious. You know, physical exam, when you're doing telemedicine with these patients, you can't listen to that heart in the patient with AFib. You can't listen to the lungs in the patient that is a few weeks post-hospitalization and is still having some cough and dyspnea. Patients are helpful in getting vital signs, pulse oximetry, even measuring leg circumferences, but the limitations are obvious. Also, there's some limitations in terms of diagnostics. What if you need labs to track hemoglobin in a GI patient? Connectivity issues are always there, but the backup is always a telephone call. The benefits really boil down to the personal audiovisual contact in the midst of isolation is so valuable. And it offers great continuity of care, a caring approach, regular support. You can switch how often you do it to the extent that you need to, and patients are very relieved and appreciative. So last slide very quickly, lessons learned. Post-hospital transitional care management is very familiar. Think about it like a community-acquired pneumonia, but remember, COVID is different, and so pay careful attention to what makes COVID unique, and you'll do very well by your patients, especially in terms of the issues of understanding and making sure your patients understand the VTE, anticoagulation, prophylaxis, isolation requirements. Pay attention to new onset or comorbid chronic disease. And remember, it really is a privilege to walk this road with patients post-hospital because they've been through a very scary experience and they're grateful to be back at home doing better. And so it's a privilege to take part of that. Thank you.
Hi, everyone. My name is Leah Lawrence. I'm a fourth-year medical student at Emory working with Dr. O'Keefe. We've been doing a QI project doing retrospective chart reviews for all patients hospitalized at an Emory facility with COVID-19 who are discharged home to better understand and characterize their specific healthcare needs at the time of discharge. Next slide. So for this short talk, I'm just going to be summarizing the very early data that we have. So this is the first 91 patients discharged from March 26th to April 1st. 88 of these went directly home. 2 patients went temporarily to a skilled nursing facility, and 1 went to a specific quarantine facility. Next slide. Just for some context, so this is a graph of all Emory inpatients with COVID-19 who are discharged home. And the time period I'm going to be talking about is between the black line. So I just want to emphasize this is very early data, and these are early patients before it got really bad or pretty bad in Georgia. So just keep that in mind as I present the data. Next slide. So the mean age in our cohort was 57. Interestingly, 56% of the group were female. 69% were African American, and then the top 3 comorbidities in the group were hypertension, obesity, and type 2 diabetes, but 88% of the cohort had at least one comorbidity. Next slide. So the hospital course in our group was relatively benign, especially when compared to the literature. So the average length of stay was only 5 days. The most common complications in the group were AKI and sepsis, both at about 25%. We had a low ICU admission rate of only 7%, and then only 1 of these patients needed to be intubated. In terms of their treatment course, it was relatively supportive. So 81% of patients got antibiotics. This was mainly inpatient antibiotics for bacterial pneumonia coverage before COVID results came back. The majority of patients also received supplemental oxygen, and then a minority of patients received some type of supplemental treatment or experimental treatment, including Plaquenil, Remdesivir, or Coletra. Next slide. So in terms of healthcare needs at discharge, these were relatively minimal. So only 8 patients needed to go home with home oxygen, and only 5 patients needed home health services. All 5 of these required PT and OT, and then 2 patients also needed a home health nurse. Next slide. In terms of follow-up needs at discharge, the overwhelming majority of patients going home needed a primary care appointment. So that was 86% of patients. Much fewer patients, 21%, required a follow-up with a specialist. And then 22% of patients needed some type of monitoring that was of their blood pressure, oxygen, INR, something like that. 11% needed follow-up labs. These were mainly CBC and CMP for abnormalities noted during the hospitalization stay. 1 patient was told to get a follow-up chest x-ray, and 1 patient needed an EGD for persistent abdominal pain at discharge. Next slide. So in terms of ER visits and readmission, so at the time of chart review, only 8 patients had visited an ER since discharge, at least at Emory. And about 50% of these were deemed COVID related. And then in terms of readmissions, at the time of chart review, only 6 patients had been readmitted to a hospital since discharge, and 2/3 of these were deemed COVID related. Next slide. So just some take-home points from this very early data. We had more females than males in this cohort, which is contradictory to the literature, so we'll have to see how that looks going forward in the rest of our data. And at least in this very early subset, these patients were overall very well at the time of discharge. They had fairly few healthcare needs, the most common being a follow-up appointment with a primary care provider. Very few patients needed home oxygen or home health services. Interestingly, the AKI rate in this group was high, so we'll be needing to determine follow-up for this, and we're actually going to start looking at this shortly going forward. And then the rates of ER visits and readmissions at the time of chart review were low in this cohort. And then, of course, a couple of limitations. As I mentioned, this is very early data. These are very early patients discharged from late March to early April. And then, of course, we could be missing complications such as ED visits or readmissions after the time of chart review. But this is an ongoing study. We're still looking at charts now, so we'll be comparing the early data to what we're getting now. So next slide. That's all I have. Thank you for listening.
I want to thank everybody for their attention. I really want to thank our speakers for preparing content today. Just really incredible. And the way we found speakers was by asking who's really out there doing this work. If you have time to fill out 4 quick questions, I don't have any future webinars planned except a morning report next Monday. So if there's content that you would find useful, you could answer these 4 questions or send me an email. Thanks again, everybody, for your attention.